Right, so who wants,
I'll take it first.
okay.
Please give me an easy one.
Okay. Just because you asked, I
Oh,
will.
really?
Just
Uh-oh, now
because
it's-
you
now
asked,
I'm
I
gonna look
will.
really bad if I don't get it. Oh,
That's.
Oh.
Easy or hard, because one never knows.
okay, I feel terrible.
So, no. 72-year-old male.
Pretty good.
I know, we're doing all salivary frozens because you'll see them. And I want you to understand how to report them. And this is probably one of the most common ones you're gonna see. Just like that sinonasal papilloma we had yesterday, when I was like, you're gonna see that. You're gonna see this on Frozen. And I remember when I was a resident, one of the GI attendings who's no longer here had one of these, and she was like, I think this is what it is, but I'm not sure. I don't know. I have to show Dr. Taxi. And so Dr. Taxi was like, yep. So you'll see it. And I want you to be confident. So go.
At low power, we have a tubulocystic lesion, I would call it, with some lymphoid aggregates. Gonna go higher. Nothing really jumped out as good for me. The low power. These cystic spaces lined by low grade / benign looking. So they have these kind of mucoid mucinous material. We have these projections into the spaces that are still covered by benign low-grade cells. This is a true lining here.
In our effect.
Yeah. Some islands, that's here. Also low grade. At this point,
What are the, if you want a clue, what are the epithelial cells, lining structures or islands? What is the
these islands.
called cell?
So
Go where there's like a not so thick of a lining, but maybe go back to the cystic spaces where there's like a thinner line.
here, are they just like ducts?
Go down a little bit.
Down this way.
Yeah, go on higher power there. And look at the characteristics of the cells. Line spaces.
They're kind of like colloidal slush hobnailing to the spaces. Their nuclei are pretty low grade in that.
Look out the cytoplasm. It's oncocytic.
Oncocytic, yeah.
You have a two. Go on.
This tumor looks like very benign, and the lining epithelium of the cystic spaces is very oncocytic and very bland looking. So I would first initially in the low power consider this as a benign tumor. and the surrounding lymphoid aggregate supports Wathin's tumor. But then in high part, I'll look for any papillary carcinoma nuclear features. Is there any Wathin's? I mean, I think this is Wathin's tumor, but there is some papillary carcinoma. There's a variant also. Right? Wathin's like.
Oh, yeah, but we're not in the thyroid. I mean, we're in the parotid.
salivary.
Yeah,
There
yeah.
was minor salivary gland, also tissue in the periphery.
Yeah. I think, can you show us the salivary gland background?
Yep.
Yeah, so,
there is a salivary
yeah.
gland.
So yes, there is a Warthin-like quote unquote variant of papillary thyroid carcinoma in which you get prominent lymphoid background. But in context, exactly, yeah. So in the salivary gland, this is a Warthin tumor, right? So the clinical history here, which I didn't flesh out, all I said was 72-year-old male with left parotid mass, but apparently he has bilateral parotid masses and increase in size in one of them, which is why they're taking it out. So what do we know about Warthin tumors conceptually, biologically? They're very significantly related to people who are smokers. They're often multifocal or bilateral, right? And they are clinically, how do they often present? How are these detected? Cystic? What? You're both right. They manifest as cystic and solid structural lesions, but they often are identified incidentally. Why?
Smoking risk, higher cancer screening.
And how do they pick them up? What are those pets, right? So yeah. So these patients often have you when you see a Warthin tumor, just be curious about the history, because often these are picked up from like the patient's got colon cancer or lung cancer or head and neck squamous cell cancer. They're smokers, whatever, and they get a PET scan and something pops up in the parotid, and then it's a Warthin. And so that's a really, really common finding. So just be mindful that that's a very common scenario. And or in this case, it just presented in and of itself as a growing mass, right? So it can do either of those things. The problem for me about Warthin here, you want a permanent. The problem about Warthin is that no one has really been able to show with certainty if they are truly clonal neoplasms. There's some suggestion in the literature that suggests that we cannot prove these are clonal. So I'm not even sure they're neoplasms. They just might be reactive lymphoepithelial proliferations, right, with oncocytic metaplasia. That makes sense because they're maybe irritated by local smoking, and they're multifocal, right? Like, so I don't know. But go ahead.
Sorry, when I was like looking at it first, because I didn't come across these during my service.
Yeah.
One thing in line with what you just said was was it I wasn't sure whether it was neoplastic versus medical.
Yeah,
From
exactly.
someone who doesn't have any knowledge.
Right.
But then my question is, grossly, does it actually form a
It's a mass.
It's a mass. Okay.
Grossly, it's mass forming. You can clearly separate it from the adjacent parotid. It always has this lymphoid stroma, and it generally is a bilayer of oncocytic epithelium that sometimes becomes a little bit proliferative, like you see up there. But if you look in the lining here, look at that lining there. It's usually bilayered and oncocytic. Nuclei kind of orient themselves nice and linearly, right? You can like see them, right?
Yeah, because as someone who really said no knowledge of it, it looks at it like very low power.
Right.
I am not sure whether this is like
Right.
forming one mass.
Yep.
Or it's hard to tell.
It's hard to tell.
Yeah,
But
good.
grossly, these are mass forming.
Okay, that's
Yeah.
interesting. Okay.
Yeah. And so we know that you can get oncocytic metaplasia of ducts in the salivary gland from reactive processes. So whether this is, cystic oncocytic metaplasia with lymphoid stroma, or whether this is really a tumor, I don't know, but just things to kind of keep in mind for future.
So when we are looking at these, say for frozen,
Mhm.
what are the malignant things that can mimic this?
So
that we-
malignant things that can mimic this include oncocytic mucoepidermoid carcinoma, which tends to have thicker epithelium, and you should see mucinous cells. But that's more of an important question on permanent, right? Because you want to make a diagnosis on permanent. On frozen, you really want to know, is it low grade or high grade, right? So even if it's a mucoepidermoid carcinoma, and you don't see mitosis or necrosis or significant pleomorphism, you still say low grade cystic salivary neoplasm with oncocytic features, like pending permanent workup, no high grade features seen. For frozen, that's adequate. For
Okay.
permanent, then you can pursue things like mammal fusions for mucoep or like immunohistochemical stains, whatever. But for frozen, that's what's most important.
Okay.
Oncocytoma, I think we saw an oncocytoma
Yeah.
the other day. Well, that has 0 lymphoid stroma, right? And that's like all solid and nested.
Right.
No, thank you.
That's good.
Mhm.
Good to come across something I don't.
Yes. Okay, thank you. Case 5, who's up?
Chat.
Yes, thank you. What, 5 account?
Yeah, we're
All right, case 5. Well, you get set up. This is a 44-year-old male with a history of left submandibular swelling, which came on 8 months ago, and has not resolved.
Left submandibular swelling.
Left submandibular swelling 8 months ago, no stone on CT scan, but enlargement. Right, so we don't really see salivary stones very much, even though they're a common reason for salivary swelling or mass forming lesions. Because they try and massage them out, they do lithotripsy. On rare occasion, they get resected, so we might see a resected stone. We sometimes see them for gross only, right? But we don't really see stones, so we don't really talk about them, but they're really common, reason for swelling in carotids or submandibular or something. All right, so this was what, submandibular.
So I'm seeing scans swallowed up by what appears to be fluid aggregates, low power. I can't find any salivary gland. Like big bands of fibrous septae between all the lymphoid aggregates.
What are those non-lymphoid structures in the back?
They look like ducts.
Mhm.
Yeah, so they're being kind of swallowed up by the lymphoid aggregate.
Yeah.
No actual glands that I can see. Looking at slightly higher power. The ductal nuclei look cytologically bland, monomorphic. Lymphoid tissue appears to mimic germinal centers. Osteocytes there. So they don't look like sheets, they're more like follicles. Points me away from a immunologic malignancy. Going into higher power. Let's see. Inflammatory cells, the fibrous tissue. Mostly it's just these kind of like germinal centers eating up. Salivary gland. Making me think this is primarily a inflammatory process. Based on the fact that there's no salivary gland left. I wonder if this is.
Well, pause on that, there is salivary gland left. You're zooming over it in these small little microacinar structures right there.
Oh,
Just-
okay, these aren't ducts, these are also glands.
Well, think about the number of ducts that you have in a gland. You expect quite this number of ducts, like those are just atrophic acini.
Oh, this is atrophic acini.
You know what I'm saying?
Yeah.
And even if you had only ducts, that would still be, that would still be indication of salivary tissue,
Yeah,
right? So just be mindful that atrophic acini can look like small ducts because you're not really seeing the cytoplasirus or the mucinous cytoplasm because they're atrophic. But they retain the duct, they retain that lobular configuration where you actually have a larger duct, right? Surrounded by these smaller atrophic acini.
Yeah.
So just to have the appropriate terminology there.
but I think this is, yeah, so primarily a benign inflammatory process involving the salivary gland. Chronic salidinitis or Sjogren's, best guess.
And so definitely it's an inflammatory process. Awesome. Definitely, I agree that there's no glandular neoplasia, right?
Uh-huh.
There's no glandular neoplasia. Here, I can give you a permanent slide. So then the question is like, what is your differential diagnosis when you see an inflammatory rich salivary process? This is an old case, so sorry about the cracking of the
Yeah.
slide, but what do we think about? You already mentioned some things like lymphoma, right? Certainly, and what features might clue you in? I don't think this is a lymphoma. It was
Yeah.
worked up as not, right? But what features might clue you into something possibly being a salivary lymphoma?
If it's just sheets of cells with no germinal centers.
Okay,
Uh,
it's sheets with rare or no germinal centers.
I think rare to see mitosis in. Malignancy, but if you saw some, you'd point.
Right, so this would depend on now whether you have a low grade or a high grade lymphoma, right? So the one thing that we always tend to look out for lymphomas, whether they be low or high grade, is how the lymphoid cells interact with the epithelium, right? Lymphoepithelial lesions or whatever, right? So when that looks like background normal
Yeah,
and it's out of focus on the screen.
okay.
So when you look in the areas of lymphoid inflammation, if the epithelium is basically like spared of the lymphocytes versus if the lymphocytes start to percolate into the epithelium, if they start to percolate into the epithelium, that's more suggestive of a quote unquote lymphoepithelial lesion, which is more suggestive of a low grade lymphoma. So sometimes you'll even see in heme these workups for salivary lymphomas where they'll do a keratin stain, not because they're worried about carcinoma, but to see how the epithelium is like broken up by the lymphocytes, right? So sometimes that's helpful. The low grade lymphomas can generally just sort of be resected, but then you risk, once you have a low grade lymphoma, then of course, like anything, you risk transformation to like a high grade B cell lymphoma. But things to think about. The other things to think about in salivary with inflammatory processes are if this was very plasma cell rich, what would you think about? IgG4 related sclerosing disease. So you may have read about these in the books called Kuttner tumors, Kuttner. And so these quote unquote Kuttner tumors are basically now known to be IgG4 related, like sclerosing sialadenitis. So if you see sclerosis and plasma cells, you may want to throw an IgG4 on there. Those are the main things in your differential. Otherwise, this is sort of a non-specific sialadenitis. There was nothing that was found in this particular case. Yeah, it's really unsatisfying, right? But sometimes you just don't know.
I remember seeing a case of ranula in one of the
Ranula?
ranula, yeah.
Yeah.
We would have to see the extravasated use.
Yeah, so a ranula or a mucocele is a process of extravasated mucin, and often with mucophages or macrophages. What makes a ranula different from a mucocele? Thank you.
You want slide
I'll take it.
Cystic space. like large cystic space?
Well, so a mucocele, they both have cystic spaces. But a mucocele is a small cystic space localized to the mucosal sites. And a ranula is a deep, large mucocele that starts basically on like the floor of your mouth, and is big and can often like plunge down and like come out your, come out your chin, right? So mucocele itself, small and mucosal located. Ranula, big on the floor of your mouth and can plunge down into your submandibular gland. But they're all, this process is the same. It's all mucophages and mucin and extravasated mucin. Let me think. The other inflammatory process we see in salivary gland is sometimes we see like this eosinophilic sialadenitis. But mostly we're dealing with tumors when it's mass forming. Yep.
What do you report this as on frozen?
This was called chronic sialadenitis with lymphoid follicles. And then the fibrosing sialadenitis with prominent reactive inflammatory infiltrate and reactive follicular cell. Yeah, so it's all reactive.
Can these patients have Sjogren's syndrome? Or like
So they can, they can. The thing with Sjogren's is it's not diagnosable on histopathology alone, right? It's always a conglomerate of clinical circumstances, serology, right? And so we often see those minor salivary gland biopsies for Sjogren, right? Which are just a little like lip biopsies. And like if the patient's serology is equivocal, often the biopsy is also going to be equivocal. So I haven't found it to be like ever like floridly just like, but if you see a lymphoid, like if you see an aggregate of 50 or more lymphocytes, and you can report it as a focus score of 1, and maybe the patient has Sjogren's. So like that's pretty much as most as I've ever gotten. And so sometimes they use that as like one of the many pieces of information to put the puzzle together, but you can't be like, yes, it's Sjogren's, right?
So do they usually give you the biopsy when the serology is negative or when it's positive? Because I feel like when it's positive, they're like, okay, you probably have Sjogren's. And then
They give it to you, I think, when it's like low level positive, or there's a weird antibody that they're not certain if it's reflective of Sjogren's often. Yeah. Like, oh, there's low level SSA or there's no SSA, but the clinical symptoms are really suspicious for it. Yeah, it's unsatisfying. Okay, next.
Some questions.
Oh, yeah, tell us.
It's actually about the first one. Is
Okay.
it another word than just the cellular version? Oh, that's this case. If it's mass forming lymphoid epithelium, the case that Alex was.
Oh, the Alex case?
Yeah,
Yeah, so the thing is, here, we can go back and look at
so the question was this mass?
it. This was, this particular inflammatory one was diffuse enlargement of the gland. But if you notice, there were areas that were maybe more inflamed and less like over here, for example, right? This area was relatively less inflamed. Area is relatively more inflamed. So arguably you could say that there's geographic, non-equal distribution of the inflammation. So maybe it presented as mass forming, but I think clinically this was a diffuse process, or mostly diffuse process that involved the entire gland, or at least the majority of the gland. And you can see that the lobular configuration of the background salivary tissue, right, is retained, right? You can see that there's these intersecting fibrous bands
Yeah,
that separate the remaining tissue into the normal lobular architecture that we often see in salivary gland. And if you look within each one of these individual lobules, you'll notice, right, that there is a larger duct and a medium-sized duct and then a small duct, and all of these small atrophic acini surrounding it, right? So that we often talk about this in breast, right? The ductal lobular like unit, like it's the same. Basically breast is a giant fatty salivary gland, right? So like salivary gland is not a small breast, just kidding. So I'm sorry, I joke with this about the breast people all the time. So this is basically a ductal lobular unit that retains the ductal lobular architecture, just happens to be inflamed, right? And so you really have to be mindful of whether that underlying salivary architecture is preserved or destroyed. So right here, again, there's sort of, smaller ducts and then lobules, but it retains that configuration. And so we talk about this ductal lobular configuration, not only in processes like this that are inflammatory, but also processes like cyalometaplasia, right? Or necrotizing cyalometaplasia, where we see this often in the head and neck service, and we can talk about it when we see it, but in these cases that have been radiated for cancer treatment or whatever, and the ducts start to undergo squamous metaplasia, they start to look like squamous cell carcinoma. But then you ask yourself, does it retain that configuration? And that's a really helpful feature to know that it is not a neoplastic process. So I hope that answers the question of whoever was asking.
There's another question
Uh-huh.
that says, can Warthin being lymphocyte-rich neoplasm present with germinal centers would make more sense if it was to be used?
So you can have germinal centers in Warthin. Yeah. And you can have varying ratios of epithelium to lymphoid stroma. But if you have zero lymphoid stroma, I would say it's not a Warthin tumor. Like, you have to have at least some, and you have to have at least some cystic spaces. But in the past case, we saw that there was even focally, right, like a really small, there was a small focus of a more epithelial rich area, right? Like, where was it? Maybe here, right, where it's much more epithelial rich as opposed to lymphoid rich. So you really have to take into account the entire tumor and say, all right, at least focally there's cystic spaces, multifocally there's lymphoid stroma, and then focally there's this epithelial proliferation. And we don't really have any words or anything to say about this more epithelial proliferative region in Warthin tumors. Like, sometimes I just see it, sometimes it's present. And as long as it's not pleomorphic or atypical or like malignant appearing, like, it's just kind of a proliferative area in a Warthin tumor. So I would still be okay with this kind of thing. Yeah.
Just seeing once we resected, these Warthins don't really recur.
No, they do not. Are those all the questions?
Yeah, I think that.
Have you ever seen a Warthin tumor with pleomorphic?
No. I've seen problems in Warthin tumors where they have metaplastic change, like squamous metaplasia or mucinous metaplasia, and then you're like, is this a mucoep or sebaceous metaplasia, right? So the thing with salivary gland, any tumor of salivary gland, is that it can have metaplastic change, and the metaplastic change has to be sorted out from like what's real and what's native to you, right? Like, we've had pleomorphic adenomas with mucinous, focally mucinous metaplasia. They're like, well, is this mucoepidermoid carcinoma arising out of a pleomorphic adenoma, or is this just mucinous metaplasia? Like, does it matter really if it's not invasive? No, no, right? Like, absolutely not. Okay, next case. Thank you. 47-year-old with a right parotid nodule. It's the only history I have. Deja vu.
So definitely have some parotid glands here with often mucin. I think necrosis as well. Maybe. Yeah, there's. And then have so there.
No.
This is what you were just talking about, right? So this is a Warthin tumor with mucinous metaplasia.
Okay, how are you gonna make that diagnosis? How are you gonna confirm that? I mean, how are you gonna? Show me the bilayered oncocytic epithelium that makes you know that it's a Warthin. Acidic?
A little bit, but not really. No. Oh, is this just?
The epithelium here arguably is thicker
Yeah.
than just bilayered, which we know, okay, we can see that in a Warthin, fine. But are these cells that are lining the spaces, are they truly oncocytic? Do they have abundant eosinophilic cytoplasm? And are they kind of columnar and tall, and do they have prominent nucleoli?
They're more like
Really?
squamous.
Yes, they're more squamoid. They're much more squamoid. And do you have as much lymphoid-rich stroma in the background? Not as much. You have some. I agree that you have some.
So is this just squamous mucinous metaplasia or?
Okay, so is it squamous mucinous metaplasia of salivary tissue? Well, it is a mass forming lesion. Why don't you go on low power and kind of look around and see if it retains. So then ask yourself that same question. Does it retain? All right, so we've noticed it's not really oncocytic, so we're not thinking Warthin. Does it retain the ductal lobular architecture of the background to make you think that it's metaplastic only?
So here there's more normal salivary gland, but no, here you don't have any architecture. It's just kind of overtaking.
Right, it's really largely cystic without retention of ductal lobular architecture. And so, I mean, yes, this is the same concept of like architecturally it has similar structure as potentially a Warthin tumor, right, with cystic and solid. But it's also still mass forming. There's only focal lymphoid background. And then you have squamoid and mucinous cells lining these cysts, right? So if something does not retain that ductal lobular configuration, I would argue it's going to be very hard to prove that it's just metaplastic, right? That's a very hard pill to swallow or a hard case to sell. It may be happening, but what is the more likely explanation in this case? Okay, like a mucosal. Would you expect a mucosal to have complex branching like multiple cysts, or more like mostly just like a single large cyst?
Mostly more like.
Okay, and arguably there's some smaller daughter cysts, so, okay. Okay, who is sure? So your colleagues, your phone a friend is saying mucoepidermoid carcinoma. Do you believe them?
Yeah,
Yeah.
I could buy that.
Okay, so tell us, group, why is it mucoepidermoid carcinoma? You're right, that's what it is.
There's mucin and
Mhm.
squamous. And I think, is there infiltrative border also?
Yeah, I mean, so low-grade mucoeps don't often have to have extreme infiltration, but yes, they can have small kind of nested infiltration
Yeah.
into the surrounding tissue. And so mucoepidermoid carcinomas don't have to be always really solid, right? They're often extremely cystic, and they can mimic things like mucoceles or Warthin tumors or cystic whatevers. But the conglomerate of features and the specific histology of the cells lining those cysts is really characteristic for mucoeps. So squamoid, or kind of squamo intermediate, and then here, why don't you look at the permanent with mucin. So all of the non-mucinous cells in mucoep are essentially of some squamous differentiation. And so they stain with things like P40, P63, and high molecular weight keratins, right? So they do appear squamous or squamoid. We talk about squamous, intermediate, and mucinous cells of mucoep, right? The squamous component of a mucoep is often not overtly, heavily keratinizing mature squamous. It's often this kind of immature squamoid appearance, which is, I think, what you picked up. What you picked up, Andrew, is saying it looks kind of squamoid. That's correct. That would be fine for mucoep. And you can get this extravasated mucin like you see here with these nests of neoplastic cells floating in it. Like that's totally okay for mucoep and doesn't make it a mucocele because the architecture is way too complex with small cysts, large cysts, branching, et cetera, et cetera.
So necrosis kind of took you off at all?
Well, I'm not sure that it's necrosis. I think it's just grungy mucin. So to call something necrotic, I actually want to see ghosts of dead epithelial cells. In this case, I think it's just sloughed off product.
So would this would be more of a low grade, right?
This would be low grade.
So in order for it to be high grade, it has to be more polymorphic, mitotically active.
Yes.
In process.
Yes, yes. So for the purposes of frozen, right, as long as you were to call this a low-grade lesion, you're fine. And it was actually called low-grade mucoep on frozen. You know, I mean, I think we could see it on the frozen. We could see it. And it was called low-grade mucoep on final. So everything correlated. But thank you for that. So let me switch you for a second. Are there any questions? Not, you got it open over there? Okay.
I found out a smarter way.
Nice, nice. Short person, I need like, help here, okay. All right. So, yeah. So the complex multicystic architecture, like we talked about, and I would argue that most of these cells lining the cystic spaces of a mucoepidermoid carcinoma, most of them end up being these really nondescript kind of ovoid to round nuclei that would be sort of regarded as almost like intermediate cell population, right? So nothing is like, frankly, like blow your socks off squamous, right? But it's this kind of squamoid / intermediate with associated mucinous gobblety looking cells. And so you can often also see it creating these complex projections into the lumen, that almost have this like tufted or like micropapillary look. Like that's also super common for mucoep, right? So even just that tufted intracystic architecture, like we see here, is really good. Yep, these just like islands of intermediate looking cells. So this is the most common. So if pleomorphic adenoma is the most common tumor, period, mucoep is the most common malignancy. So you will see it. So I want you to burn these features into your brain, right? And we can certainly look at more mucoeps, but this is a nice example of a really cystic mucoep. Okay.
So they can be a lot more subtle.
Yes. With so many mucinous cells, you really have to, you know, that's a lot, right? That's a lot of mucinous cells for just metaplastic change. But yes, the features can be more subtle than this. It can be more solid as well than this. It can be arguably cystic than this, but you can certainly get more solid than this.
This is my first time actually seeing the real case.
Hey! Who wants to do case 7? 7 is a really fun one. Thank you. 53-year-old female, parotidectomy for left parotid mass.
broad line from all of the more I think the psychological feature for this also always on high grade. Like dilated with the cystic areas.
So what is gonna be your diagnosis on frozen? Low-grade salivary lesion, fine, okay, cool, because at the time of frozen, that's pretty much all they need to know. But here, why don't you take a look at the permanent? Now we have to get to the diagnosis. There's your normal.
Normal one
Mhm.
is 12.
Yep.
It's being well. Large, small.
I would caution you on using the word hyperplasia if you think this is a tumor. Right, because it's a different process. If this is a neoplasm, it's a neoplasm. If it's a hyperplasia, it's different. So do you think this is a neoplasm or a hyperplasm? I think this is a hyperplasm. Because why? Okay, can you have such a thing as a benign neoplasm?
This is benign.
Okay,
So like benign.
okay. Maybe we need to review what hyperplasia versus neoplasia is. Do you think this is a tumor?
Yeah.
So how is a neoplasm different from a tumor? Can you help us out?
The neoplasia means like new growth. So I use neoplasia and tumor interchangeably, and they can both be benign or malignant. But hyperplasia, I think of just normal cells that are being stimulated, like hyperplasia, like a parathyroid, for example, when you have parathyroid hormone, it's just stimulating the cells to grow, but it's not necessarily like, it's not a clonal process, yeah.
Clonal processes.
So a clonal process is in the words we use in today's world, right, is both neoplasm and tumor, right? Okay, so a hyperplasia is a response to some external stimulus, right? Whereas a neoplasm is a genetic, epigenetic, or proteomic change in the cell that drives proliferation independent of the outside world. So neoplasm and tumor are the same, right? Neoplasm can be benign or malignant. So if you're calling this hyperplasia and a tumor, those two don't colloquialize, right?
Yeah.
Okay,
No.
not
That- that's
hyperplasia.
not-
Proliferation is a more generic word, but when you say hyperplasia, that's specific to this concept of stimuli. All right, so go. So this is a tumor / neoplasm, but we all think right now that it's benign. Okay, cool. So far, we're all on the same page. All right. So then we have to come up with a differential diagnosis, and that's probably the hardest part.
Yeah. This is like
kind of tubuloductal structures, I agree. Yep, you can have some kind of adenoma. If we are thinking that it is a benign neoplasm of salivary epithelium, by definition, it is an adenoma, then the question is what kind of adenoma? Then we have to stop. Okay, okay, cool. No, that's fine. Who's got a differential?
Like a basaloid neoplasm.
Mhm.
So this one that I thought of was
Thank you.
adenoid cystic.
The first one that you thought of was what?
Adenoid cystic.
Okay.
But then it can be a PA. It can be a myoepithelium. It's very cellular. It's very basaloid. It can be basal cell adenoma. So
Uh-huh. Yeah, so it doesn't really have the infiltrative growth pattern of an adenoid cystic, right? It's like extremely circumscribed
very
and arguably doesn't, I mean, yes, adenoid cystic can be totally tubular, but it doesn't really have, this doesn't have the cribiform pattern or the kind of
exactly.
mucinous or the infiltration. It's super, I mean, it's extraordinarily circumscribed. So then you're thinking about, you said pleomorphic adenoma. So it's missing, I mean, you can have a cellular pleomorphic adenoma, right? You're missing what?
The chondromyxoid.
You're missing the chondromyxoid stroma, right? Okay. But you have these tubuloglandular, tubulocystic spaces, okay. So then the other thing you said was what?
Basal cell adenoma.
Basal cell adenoma, or tell us about basal cell adenoma.
It's actually a biphasic tumor.
It's actually a biphasic tumor, yeah, just like PA.
Yeah, just like PA. And it can look like this.
And it can look like this. So it's cell adenoma. So what do you want to see?
2 layers.
2 layers. So let's start the two cells that I always want to do to see the 2 layers are what?
C117 and P63, P40.
CD117 for the epithelium and P40 for the myoepithelium. So P40 is in salivary gland is much more specific for myoepithelial because you can get aberrant P63 staining in cells that are not myoepithelial, and this becomes most important in polymorphous low grade. All right. So I always, if you want to do P63 and P40, that's fine, but don't not do P40. So this is P40, and so you can see, right, that it's staining the outer or like the abluminal, right? It's staining the abluminal cell population of this process. And so I would always urge you when you're looking at a salivary gland neoplasm, don't just say it's positive. Say where it's positive, because often you can have biphasic or mixed neoplasms in which you want to specify the nature of the cells that are staining with each of these markers, right? So P40 is specifically staining the abluminal or the myoepithelial cell population. CD117 or c-KIT is staining, right, the luminal cell population, and the abluminal cells are negative. So this confirms that biphasic population. So you know, if you have this pattern, this like positive, negative, negative, positive, you know you're dealing with one of a very few specific things. Those that are biphasic or biphenotypic. And so in my lectures, you have the whole chart of what that is. But in a circumscribed, non-infiltrative, low-grade, presumably benign thing, right? You're dealing with something like a basal cell adenoma or a pleomorphic adenoma that has a dual cell population. The morphology, as already suggested, is highly cellular without chondromyxoid stroma with this tubulotrabecular pattern. So you're already thinking about basal cell adenoma. What one other stain can help you confirm that? What? I'm going to put it on the scope. So this stain is focally membranous in the luminal cell population, but then in the peripheral abluminal cell population, you also see nuclear expression. Does anybody know what this is? Beta-catenin, yep. So beta-catenin this is what we didn't have in that basal cell adenoma we had the other day, but you know, not 100% of basal cell adenomas have beta-catenin mutations, but those that do tend to have nuclear expression of beta-catenin in the predominantly the myoepithelial cell layer. in which other neoplasms do not, all right? So PA would not do this. PA would have the biphasic P40C kit, but it would not have this cute little beta-catenin at the periphery, all right? So this is super, super helpful for basal cell adenoma. The other ingredient you might read about in the literature is LEF1, LEF1, but which, yes, also stains the myoepithelial cell population of a basal cell adenoma. But I've also seen LEF1 positive PAs, so I wouldn't, and other neoplasms, so I don't regard LEF1 as that great. The other thing that we see in basal cell adenomas, and I'm belaboring this point because we don't see these that often, but when you do see them, they are like, they're super characteristic, and this is a classic one. The other component of a basal cell adenoma that is a little bit more subtle is the cellular stroma. So I'm going to try and find some of the cellular stroma. So in the background between, here we go, between the epithelial cells, can you see in areas, there are these spindled cells between the epithelial cell islands. So you will not find that chondroid or that chondromyxoid stroma, but you will find a fibrocellular stroma, okay? So this fibrocellular stroma that's sneaky and subtle in between the epithelial islands is really characteristic of a basal cell adenoma. And it stains strongly for S100. So you can see, if you look carefully, yes, some of the epithelial cells or myoepithelial cells are staining for S100, like these weaker ones, but these stronger wisps in the background, these are the spindle cells of that fibrocellular stroma in the background between the NES and BCA, right? So this is super nice to see. So that's why I like to do the S100 in these cases, because the strong bits, those are all the stromal bits, right? So to me, this is a very, very, very lovely, here's more example of a classic basal cell adenoma. So these don't have flag or polymorph. They don't have the pleomorphic adenoma gene rearrangement, right? They have the beta-catenin mutation. So they're different. They're not PAs. They don't really have the same propensity to recur or transform like PAs do, even though the differential diagnosis is certainly a cellular pleomorphic adenoma.
They can transform to a basal cell carcinoma.
So whether they transform to a basal cell carcinoma or the basal cell carcinomas arise de novo, still not determined, but yes, you can have the morphologic equivalent of a basal cell neoplasm, which if it is infiltrative, is a basal cell carcinoma. Basal cell adenocarcinoma, I should say. No. BCC, basal cell carcinoma on the skin, BCA, basal cell adenocarcinoma of the salivary gland. And those can have either beta-catenin mutations or CYLD, the cylindroma gene. So you know the cylindromas of the skin, like the turban tumor, that's like the characteristic. So CYLD gene is more commonly mutated in basal cell adenocarcinomas, but they look morphologically essentially identical, but with infiltration. And if they have the CYLD gene mutation, they would not have beta-catenin expression in the nucleus.
It's 9 o'clock, but could we go back to the frozen section once again?
Of the BCA?
Yeah, BCA. Because
So you have a
yeah,
tiny little carrot of parotid tissue out here that's not involved. And here's the frozen.
I thought it was a little more kind of stroma rich on frozen versus permanent. I think it looks okay.
Yeah, I think you're getting nice like widening of the widening between each of the tubuloductal structures, maybe because of edema or ice crystal artifact, but you're getting separation of the tubuloglandular structures.
Yeah, so I was like, is that like desmoplasia on frozen? But then like when I look at the permanent, everything looks so
Squashed.
squashed and safe, you know, safe.
Right, right. Right, so
versus here.
that background probably is some of that fibrocellular, right, like S100 stuff.
Yeah,
Yeah. So it's, I mean, you always wanna, if you can, go look at the growths on these, because
right.
you would have been able to see how circumscribed it is grossly,
Uh-huh.
right? And,
Yeah.
and how you have a nice border. So that's always an extremely useful finding for trying to interpret the frozens on these. Here's also arguably, one could cut deeper, because I don't think this was fully faced on frozen either, right? So this is the full face for permanent, where you can actually see much better the interface and the circumscribed nature of it, right?
Is the staining essential for confirmatory diagnosis?
Staining is not essential. If you are comfortable with the H&E morphology. So sometimes my personal pattern has been, when a tumor is new to me or uncertain, I will do the stains for the first couple times. And then once I get used to it, like I kind of stop doing it just because I now am used to the morphology. But I would never say, no, don't do it. I would say, if you want it, do it, but you don't like need it if you're comfortable enough.
Like there's no like very similar pitfall that if you don't do the staining, like.
Right.
We have a question on the chat saying
Yes.
CYLD1 mutation would not be an adenoma.
Correct. Beta-catenin mutation could be an adenoma or adenocarcinoma, but generally CYLD mutation is only adenocarcinomas, interestingly enough. Yep. I mean, at least based on the literature. These tumors are pretty rare, so who knows, but at least based on the literature, that's what it seems to suggest. Question for next time. I have like 4 more of these. Do you want to finish them or do something else?
I personally want to finish them.
Okay,
These are really
finish
good.
them and then move on to something else. Okay.
Sounds good.
Thank you.
Thank you.
Thank you.
Okay.
Thank you, everyone.
Yes, James.